So previously, when we talked about the hematologic disorders, we discussed things like hemophilia. This is a potential for your pediatric patients. This is a congenital condition in which the patient lacks normal clotting factors. So it's probably known that they have this, maybe even since birth. It's usually hereditary and fairly severe. It's predominantly found in the male population, and they might be receiving some type of special medications or administration of some type of injection to treat this, like factor 8. So you just want to make sure that you ask about those things, because remember, no matter how minor, those injuries could be life-threatening for them. For altered mental status, there are some things we want to consider here. Understanding the developmental changes, know what's normal for the child, asking the caregiver's opinion. Is this an appropriate response to you or is it not? The signs and symptoms of altered mental status may vary, and the AEIOU tips is just simply a mnemonic for us to try to remember potential causes of altered mental status so that we can try to rule some of these out. So things like alcohol, epilepsy, endocrine disorders, electrolyte imbalances, insulin, opiates and other drugs, uremia, which would be kidney failure, trauma, temperature, infection, poison, psychogenic issues, shock, stroke, seizures, syncope, and space-occupying lesions or subarachnoid hemorrhages. So I know that's a lot to remember, but just thinking as much as we can possibly rule out for thinking about altered mental status. So seizures, as we discussed during the neurologic chapter, this is the result of disorganized electrical activity in the brain, and it can manifest in a variety of ways. It can be very subtle in infants with just an abnormal gaze, sucking, and bicycling motions. More obvious in older children with repetitive muscle contractions and unresponsiveness, but just thinking about the types of seizures. Is it a generalized seizure, which would involve the whole body? Is it a focal seizure where they're just staring off into space? Is it, an isolated to one area of the body? Some potential causes of seizures: child abuse, electrolyte imbalances, fever, which is really the big one, also hypoglycemia. Those two are pretty huge for our pediatric population. Infection, ingestion, which would be ingestion of poisons or toxins, lack of oxygen, medications, poisoning, seizure disorder, recreational drug use, head trauma, or no cause could be found. And so that would obviously, when there's no known cause, then we really would probably get the diagnosis after a few doctor's appointments of epilepsy for the child. Longer and more intense seizures can take longer for the imbalance to correct itself. So remember, they might stay in that postictal period for a longer period of time. If the seizures continue recurring, or if it seems prolonged, like a status epilepticus, we might need to call for ALS. As far as management, not much that we can do other than just removing anything that's going to potentially harm them from away from them. We don't want to put anything in their mouth or ever hold them down. Looking at meningitis, this is inflammation of the tissue that covers the spinal cord and the brain. So being able to recognize a pediatric patient with meningitis can be an important skill to have, but it can also be very difficult. Individuals at the greatest risk are males, newborn infants, those with compromised immune system by AIDS or cancer, history of brain, spinal cord, or back surgery, children who have had head trauma, children that have shunts, pins, or other foreign bodies in their brain or spinal cord. The signs and symptoms will vary by age. This is caused by a bacterium that causes a rapid onset of meningitis that often leads to shock and death. The children might present with small, pinpoint, cherry red spots or large purple or black rash on them. And this is just an example of kind of what that looks like that can be classified as meningitis. Patients with suspected meningitis should be considered contagious, so using proper PPE. Also, this patient will probably have a fever, and the only definitive way to determine this is for them to do a spinal tap at the hospital. So again, not something that you can really diagnose in the field. Gastrointestinal emergencies, so never take a complaint of abdominal pain lightly. We want to monitor for signs and symptoms of potential shock, if it could be related to internal bleeding. The origin of this might be coming from ingestion of certain foods or unknown substances. In some cases, the patient might be experiencing abdominal discomfort with nausea, vomiting, and diarrhea. Appendicitis can also be fairly common for the pediatric patient. So, thinking about the presence of rebound tenderness on the right side. Remember, rebound tenderness meaning that in the right lower quadrant, we are pushing in and it feels better, and when we let it go, it hurts more. That's rebound tenderness. They probably have a fever with this as well, maybe some nausea, vomiting, and that lower quadrant abdominal pain. So, that would really be signs for us to tell that this might be what's going on. Looking at poisoning emergencies and management, these are unfortunately fairly common among children, whether they pick up medications of their parents or grandparents thinking that they're candy, whether these are things they come into contact with like cleaning supplies under a kitchen sink. The signs and symptoms will vary depending on the substance and also the child's age and weight. They may appear normal, confused, sleepy, or unconscious. Sometimes it can just take one pill to be lethal, so we do want to make sure that we are doing a thorough assessment and providing prompt treatment. We want to be alert for any signs of abuse to see if this was an intentional poisoning. So we're looking to see what is the substance involved, approximately how much was ingested, what time did the incident occur, were there any changes in behavior or level of consciousness, has there been any choking or coughing after the exposure, and then we want to contact poison control for assistance to help us identify the poison and also treatment that we can help to provide, even if it's something like a household substance that could help neutralize the item, like milk or water. Dehydration emergencies, these occur when fluid loss is greater than fluid intake, so vomiting and diarrhea are common causes and can lead to shock and death. Infants and very small children are at the greatest risk. This can happen in a matter of hours if they're not able to eat, that they can become dehydrated to the point of it being a life threat. So that dehydration can be mild, moderate, or severe. So things that we're looking for here are going to be poor skin turgor, so tensing that skin up, and we should see it returning back to normal very quickly within about 2 seconds. Also for infants, you might see that the fontanelles, those soft spots of the head, are actually sunken in if they are dehydrated, so that could be a telltale sign. If the child is old enough to change positions, like from sitting to standing or laying down to sitting up, then we could check the orthostatic vital signs same as we would for an adult patient. But we're going to ask again about those bladder habits, specifically how many wet diapers have they had, how much have they had to eat and drink, that type of thing. Looking at fever emergencies, this is an increase in body temperature. Generally over 100.4 is what's considered an actual fever. And while it's rarely life-threatening, we want to get to the underlying cause of what is causing the fever so that it can be treated. And it really depends. Under 100.4 doesn't necessarily require treatment. Some parents may just prefer to administer it to a low grade temperature, but usually the body is trying to fight something off. So keeping it letting the fever run its course at that point can actually be of benefit. Now, once you get to the 100.4 degrees Fahrenheit, then you can consider administering usually the one of the two, either Tylenol or ibuprofen, to help treat it. This usually comes from a lot of different things. It can come from bacteria, it can come from infection, it can come from teething, a lot of different stuff that can cause fevers. So make sure that we are keeping the child as cool as possible, removing as much clothing as possible, maybe down to a diaper. We don't want to put them in cold water or change the temperature quickly, but maybe a lukewarm bath to help bring that temperature down. Recommend this to the parents as well. If the patient presents with respiratory distress, shock, a stiff neck, a rash, very hot or flushed skin, and bulging fontanelles, that would be bad findings there, okay? Looking at febrile seizures, this obviously comes from a fever, and so remember, we've talked about this before, but this is not always related to how high the temperature is, but usually how quickly it got there. And so the most common age that this happens is between 6 months and 6 years, although it can happen really to anyone. And it is just caused by the temperature, but it's not always about how high it is. It's more about how quickly it gets there. So if we have a long period of time to adjust to that, like they've had a fever for a couple of days and it's just getting increasingly higher, the body has had time to compensate and adjust. If we develop a temperature of 101 over a period of 30 minutes, then the body doesn't really have time to adjust to that, and we could see febrile seizures. So the treatment is going to be the same as for any type of seizure, just to keep them safe and out of harm's way for as long as possible. Ultimately, once they wake up, we do want to worry about bringing that temperature down. So some of those medications, if they're able to swallow, Tylenol or ibuprofen, and then the lukewarm bath, removing as much clothing as possible, that type of thing. So looking at drowning emergencies, we want to, of course, maintain our own safety, and we'll look a little bit closer at drowning emergencies when we get to the environmental emergencies chapter. This is the second most common cause of unintentional death among children, and children younger than 5 are at the highest risk, usually because they don't have much experience with swimming, and so they go into like ungated pools. Alcohol can frequently be a factor with adolescents, so thinking about those teenagers who are acting reckless around water at oceans, pools, lakes, that type of thing, where alcohol has been involved. The principal condition here is a lack of oxygen moved to the brain, so within just a few minutes it begins to affect the heart, lungs, and the brain. Hypothermia from submersion in icy water can actually be a good thing. Again, as we'll look at in the environmental chapter, a person is not dead until they are warm and dead. So someone who is hypothermic, like from cold water drownings, or if they've been outside in a hypothermic environment, it essentially stops the body and puts it at rest. So you have a lot more chance of having a successful resuscitation from someone who has been in a hypothermic state. So just something to consider. Pediatric trauma, this is the #1 killer of children in the United States. The quality of care can impact recovery, so you want to make sure that you are providing appropriate spinal stabilization, that we are using appropriate splinting and hemorrhage control techniques, whatever we can, to help get the patient to an appropriate facility. And that appropriate pediatric trauma facility is also very important that we transport them there. Older children and adolescents are more prone to long bone fractures than smaller children. But smaller children may have a different location of injuries. It might be joints. The child's bones and soft tissues are less developed than that of an adult, and the force of the injury is going to affect the structures differently. So like we mentioned before, the child's head is going to be proportionately larger, making it very prone to injury, especially deceleration injuries, or if they were to fall into a body of water or even a small pool, just 1 to 2 inches of water could be enough to drown them if they fall face first and can't get back up due to the weight of that head. Looking at injury patterns, and we'll look more at this in the full trauma chapters, but it's very important that you understand physical and psychological characteristics of children when we're considering injury patterns. So thinking about the vehicle collisions, and specifically children darting out in front of motor vehicle accidents can cause a variety of different injuries. Usually if it's an up and over from a smaller vehicle, maybe this vehicle struck the child at very low to the ground, lower legs up to the knees, then it pushed them up and over, so they're looking at more head injuries, and then also the legs. If it was down and under from a larger vehicle, or it actually went underneath the vehicle, then you're looking at more skin injuries like road rash, and also burns potentially from the underside of the vehicle. Sports injuries are kind of common as well with organized sports, so head and neck injuries occurring in contact sports like football, wrestling, ice hockey, field hockey, soccer, and lacrosse. So making sure that we remember to immobilize the cervical spine, and if they have a helmet in place, are we going to leave it or are we going to take it off? It will depend on the type of helmet and the situation. As long as it's not impeding with our management of the airway, most of the time we can pad it and just leave it in place. But again, we'll address that more in the trauma chapters. I'm going to leave off right here, and we'll pick up in the next video.